Hello, everyone, and welcome to this virtual meetup. We apologize for our late start. Had a few technical issues. Welcome to this new virtual world that we live in. Which maybe it's apt that we had a few tech challenges, since I think our patients, the patients we serve, deal with this all the time. So maybe that will be a topic that will come up as we talk about achieving fluid telehealth and really how do we create a virtual care infrastructure that's supportive of patients, which we're excited. We even have a patient on our panel today, and also providers, clinicians. So we have an expert panel here. So let's go around and you have each of them introduce themselves. I guess we'll do ladies first. So Stacy, do you want to start?
Well, thank you so much, John, for having me today. My name is Stacy Hurt. I am a former healthcare executive in pharmaceuticals and physician practice management, turned stage 4 colorectal cancer survivor and caregiver of my 14-year-old special needs, completely disabled, dependent son. So in between my full-time jobs of being a caregiver for my son and being a stage 4 cancer survivor, I am also a patient experience consultant. I do content creation for health systems and industry from the patient perspective, as well as a hands-on patient advocate for those in need, dealing with various types of cancer and disabilities and inclusion.
Excellent. Atif, do you want to go next?
Yeah, good morning, everyone. My name is Atif Chaughtai. I've been in healthcare space for about 20 plus years. Started my journey at National Institutes of Health, where I was enterprise architect. And I got to see the clinical side and also the research side. So they call it the translation medicine and also the medicine that in terms of doing protocols. And I work currently for Red Hat as a healthcare market lead for North America, which covers US and Canada.
Excellent. Glad to have you here. Marlon, you want to go next?
Yes, good morning, good afternoon. Marlon Harvey. I'm a global business solutions architect for Cisco. I've been doing healthcare now for almost 13 years. He initially started off in Canada as an Ontario province-focused, healthcare solutions architect, and evolved into a national role within Canada. And approximately 3 years ago, I took on a global role and a global focus. And the mandate really is to work with providers in terms of understanding the business challenges, and then formulate the appropriate solutions with both Cisco and ecosystem partner solutions. I think what's interesting about this conversation today is it is at a point in time in which we truly need to be partnering, we truly need to be collaborating, and we truly need to be listening to the requirements of our actual patients and customers. So very happy to be participatory to this activity today. Thank you.
Yeah, thanks for joining us. And I guess you just celebrated Canadian Thanksgiving. You get a double dip now. Is that how that works?
I did not, unfortunately. Cisco America is working. I had to work yesterday, so I'll get my turkey.
That's too bad. That's great. And last but not least, and unfortunately his camera is not working. I hear he's traveling a bit, and so that happens. But finally, Dr. George Mathew, you want to introduce yourself?
Hi, everyone. I'm Dr. George Mathew, as John said, and apparently I'm the proof that technology doesn't work 100% of the time, but most of the time it does, if you can see the rest of the attendees. I'm an internal medicine doc, but I also act as the Chief Medical Officer for the Americas for DXC Technology. We're a global IT systems integrator, and at least in the States, we play in the payer, provider, life sciences, state and federal government businesses. We do everything from business process outsourcing all the way to analytics and everything in between. So, and I help with the healthcare sector, and again, thank you for letting me be here.
Yeah, so it's great to have you all here. Let's dive into this conversation, and I want to start by saying there's some things we're not going to talk about. We're not going to talk about is telehealth exploding, right? Like that's a given, right? It's there, right? We're not going to. That's just the reality, right? And we're not even going to talk about do healthcare organizations need a strategy. I think everyone's clear on that, right? Instead, for this discussion, we really want to talk about what virtual care infrastructure is needed. What do organizations need to be doing? What do you see them doing? And what are you working with your customers on? Or, in Stacy's case, what do you need as a patient, and what are the gaps that you've seen? So let's start with that. What are some of the gaps healthcare organizations are finding when it comes to virtual care? Dr. Mathew, maybe you could kick us off.
Sure. I'll throw it in. I'm very interested to hear what the other panelists say because they probably have their hands in it pretty deeply as well. And Stacy, obviously, I want to hear your perspective. But for me, it seems that for a lot of folks, you had made the statement that people are starting to plan around telemedicine and telehealth. I don't know if we're fully convinced yet of that. I know, obviously, people have converted over to telemedicine back in March and April, and now in the last couple of months, I feel like they've been trying to make hay while the sun shines and do as many fee-for-service elective procedures as possible to make up for the revenue loss. I do think, though, there's still a little bit of a disconnect for many of the healthcare institutions and hospitals out there to really make virtual health one of their product or service lines. Too long, and really up until this year, the beginning of it, it's seen as an adjunct or an extra or an add-on. But more of an afterthought than really a centralized business line. I think some of the systems have started to, or we're in the process of creating a virtual medicine or virtual health platform that would integrate it in some way. But we've done 20 years of change in 6 months, and we're still learning. For example, which visits benefit most from a telehealth visit versus not. So I think we're still in the early innings of it.
So do you see that a bunch of organizations are ready to roll back to the way we've always done it? Is that kind of what you're suggesting?
I think many are getting ready to do that. I think until reimbursement is kept at a certain level of parity, I hesitate to compare it to an addictive illegal drug, but fee for service in a lot of ways from a revenue perspective is that it's hard to give it up.
Wow. That's an interesting take. Atif, do you agree with Dr. Mathew, or how would you look at it?
I think I agree from the perspective of we took 20 years of transformation and cramped it down into several weeks or months of transformation that healthcare happened. So from a telehealth perspective, CMS for Medicare and Medicaid didn't use to provide reimbursements, right? They were not considered official visits. So that change happened legislatively very, very fast. So we had this boom, and then, tools like Zoom or whatever else skyrocketed because everybody was using them. I do see that essentially this change that has happened probably will progress and continue to be that way. But I think some of it will be pulled back, as he mentioned. So just based on some personal experience I had recently, a dentist having a virtual consult is not going to help very much, right? That is a touchy and feely thing. But a virtual consult hey, I'm having these symptoms with a PCP is a different story, right? Or a follow-up is a different story. So I think that demarcation line needs to take place. But I'm very hopeful that we will not roll back the progress we had. In one of the aspects of all of this that has also highlighted is how siloed our healthcare system from a data perspective is. And that information and lack of information has created other challenges where the platforms they're using and what tools they're using to provide traditional in-person care are not marrying up very well. Even, for example, you have to be in a facility to access those tools, for instance, in certain cases. And that itself highlighted this whole challenge, which I think also lines up very well with the CMS mandate for that interoperability for data sharing as well.
Yeah, and I think you just hit one of Stacy's favorite things, probably trying to get access to the data as a patient. But it sounds like what both of you are saying is that what we need, the gap that's existing now, is knowing what should be virtual and what shouldn't. It sounds like that's the challenge that many organizations are facing. And then, related to that is, okay, and how am I going to get paid for it as well? Is reimbursement going to continue? The unknowns around that. Stacy, do you want to add anything to what Atif and Dr. Mathew have shared?
Well, both excellent points. I stand with Atif in saying that I will absolutely, positively not let a rollback happen. And that's from the perspective of speaking for many patients and caregivers who need this. So, from my perspective, battling stage 4 cancer, I mean, there were times when I could not leave my bed. I was so sick from chemotherapy and fatigue and nausea. And in terms of checking in with my doctor, instead of literally dragging myself to the oncologist's office and exposing myself to a bunch of germs, it would have been better to consult with him from the comfort of my home. And, Stacy, how are your symptoms? How are you feeling, et cetera? That all could have been done by telehealth. Same with my disabled son. He's 90 pounds. He can't walk. I have to lift him into his wheelchair, into our accessible van, bring him out, lift him again. And we just had an appointment on Friday morning with genetics. And it was a follow-up visit. And even the physician herself, the geneticist, said, for follow-up visits, telehealth is the way to go. For an initial visit, to do a physical exam, et cetera, look at the anatomy, yes, an in-person visit is the way to go. But it's figuring out, as we talked about here, how to integrate telehealth into a patient's profile, if you would, their health history. And I think if anything, we need to educate patients more of how to use telehealth as a valuable tool in their care management. And I don't think that we're doing a good job of that. And where does that come from? I think that, of course, that comes from patient advocates, but I think that comes from health systems and providers of saying, you could do this via telehealth, this particular visit for this particular issue. I also, like I said, prior to being on this side, being a patient and a caregiver, I was an executive. I worked in healthcare management. So I definitely understand the reimbursement piece of this, and we absolutely have to make this worth providers' time. We have to reimburse them for this service and make it worthwhile so that they want to promote it and use it. So I want telehealth to be here to stay. I am a very satisfied user. I'm one of the 86% of satisfied patients in the new JD Power survey. And I think that, again, we all have to work together to make it stay, for sure.
Absolutely. Well, Marlon, we want to loop you in as well. I mean, it's interesting. Stacy really puts it forward. Will patients allow us to go back to regular visits, or will they just opt to go to someone that offers a virtual?
Yeah, I think what's interesting so far about the narrative and the different points of view shared by the other panelist members are, you have Dr. Mathew, who is actually part of the provider group. You have Atif, who is actually looking at things, bringing wisdom and experience from different roles within healthcare. You have Stacy, who is the patient, who's the customer, who's the client, who has the capabilities and is really looking for a service capability or service experience that allows her to interact and leverage healthcare per her actual specific care condition and her family's care condition. I also think some of the things that have been mentioned are going to be triggers for how telehealth evolves. And I think geographically, the US is one theater in which the conversations thus far is specifying policy, right? Governance, reimbursement are key factors that may cause behavior in terms of how the provider actually continue to offer services. I think this little thing we have called this virus that we're still trying to figure out is going to influence how long we are challenged to determine what does a telehealth or a virtual care set of services look like, and how do providers leverage these particular pathways of interacting with patients to deliver care experiences that does not require the patient or the provider to be physically in contact with each other, right? The two other things that I believe are really triggers to explore in the conversation. One is the digital capabilities of the consumer environment today is so rich in terms of mobile, right? And the quality of the actual endpoint experience, that's going to actually impact the demand from the patient population on the system in terms of the providers. That's going to influence policy and governance decisions. That's going to influence fast track and reimbursement activities. Secondly, I think the service provider environment in terms of organizations like the EMR organizations like collaboration capabilities such as what Cisco, Zoom, and others provide, and also what the internet providers are actually able to actually provide today in terms of enabling 5G and other rich type of connectivity options. Those are the triggers I think is going to influence whether or not we see an extension and an evolution to value-based virtual care versus fee-for-service in terms of how we currently operate today.
Those are some great points, and I think you highlight one of the challenges that we wanted to discuss. I think there's 4 areas that we kind of highlighted in the preview of this. One is around infrastructure. The other is privacy and security, which we could go a long time on that. Connectivity, which you talked about, and then of course data access and interoperability, which Atif has kind of touched on a little bit already. If we just talk about like the infrastructure and connectivity pieces, to me, I think that's one of the big challenges that we see. Do patients have the connectivity that they need? Not everyone is created equal there, right? Luckily, the bar has come down, and and more people have what's needed to be able to do it. But then I think also if I'm a healthcare organization, I need infrastructure that can scale as needed. Because as you pointed out, Marlon, the question is what's going to happen with COVID? Right now, you may be open, but 3 months from now, you may be closed and have to go back to virtual care. So what's needed for that? Maybe Dr. Mathew, you want to hop in there and, what should a healthcare organization be doing to plan for the infrastructure needed for these, maybe it's spikes in virtual care, is that maybe how I describe it?
It's a great way to describe it. It's interesting because of the fact that, if COVID, and Marlon, it's great that you brought it up too, it's acted as an accelerant, right, for just about everything. Everything we thought would take another 5 or 10 years, 6 months. So for an organization to kind of plan for that, they have to start really sussing out, what does a virtual offering look like? What is my combination, just as Marlon and Atif and Stacy have said, what is my combination of hands-on and remote look like? And what's the combination of technology? And, there's an old phrase, high tech, high touch, from John Naisbitt in Megatrends. Every time you get more advanced with technology, you need to have a more personalized touch. Otherwise, you risk alienating the same people you wish to be your customers. And I think that's really the thinking through that a lot of organizations have to do. We've actually been in contact with several organizations that are looking to go beyond their state borders. They're large, well-integrated systems. Usually they have a payer integrated with them as well. And they're looking to go, well, we're already in 3 states. Why can't we go after the other 47? Why can't we offer it? And obviously, because of the emergency situation, the regulatory situation changed where emergency orders have been put in place to allow to go across state borders and offer telemedicine services to a certain degree. Again, it's specific cherry-picked services, not everything. But I think that whole idea of bringing it in as a fully thought out business and service line and not an add-on, as well as what the business model should look like for that, that's what a lot of organizations are going to have to do. And then be able to, quite honestly, change service lines. I'm from Detroit originally, so we think of anything as an auto assembly line. You just have to be able to change lines depending on the demand.
Interesting. Well, and a lot of those, large brand name organizations are looking at it from a global perspective. It's interesting the legislation or the concepts of state regulations. Talkspace recently said, we'll pay any legal fees for anyone that practices across state lines and runs into trouble, which Anyway, that's another topic, but I mean that they're trying to push that boundary because it's so important. Atif, it looked like you were itching to talk in response to that, but I think it also applies to interoperability. To me, the infrastructure, okay, now you're practicing across the state line, but then that brings in new interoperability challenges. That brings in a lot of new infrastructure challenges. What's your thoughts on what Dr. Mathew shared?
I think from a technology perspective, I'm going to go out on a limb and say something very controversial. But I think this is what's going to happen from a technology perspective. People are going to innovate on this telehealth so much that it will surpass a personal visit. Let me explain why.
That would be great.
Bringing in, bringing in AI, ML. So even, for example, when we are on this webcast, our cameras are on, AI, ML with face recognition can tell a lot about what the person is. So for example, like if you are having a telehealth consult with a physician, based on your voice level, based on other indicators, based on the picture of your face, and the AI ML can scan and maybe catch some details that a physician who has to see, 60 patients in 6 hours might not, right? And suddenly now you have this assistant that is doing the detailed analysis and giving you, hey, did you notice that, Atif has this bump on his neck that was not there during the last consult? Is there something of concern, right? And that would not necessarily be caught. So I think when that level of sophistication takes place, and we already know like some of the cloud vendors out there, we're using collaboration tools, have now AI bots that you can bring in and that can transcribe your discussion, take action items for you. Similarly, I think that's what's going to happen on this side to help scale even the physician assistants who eventually, hopefully be allowed to do this. And then the AI ML complements the actual doctor's knowledge to support that interaction. So I think on that side, then you need an infrastructure that is really very scalable to make that a reality, right? And that infrastructure probably is very, very much like Netflix style. Like, at 8 p.m. Eastern Standard Time, a lot of people join Netflix. Services go up, right? Start streaming. Then West Coast comes up, they start at 7 p.m. So another spike happens and, there's spike shaving going on. So you need a very flexible infrastructure like that. But going back to all of this is only possible if the data challenge is resolved, especially the cross-state collaboration that you're mentioning. It was very difficult in the beginning where each physician, based on where they're licensed, had to get an approval from the state to practice telemedicine. And that was a big process to go through, right? Yep. Even in our traditional onboarding of physicians into hospital systems, you have to go get a certification and clearance from DEA. Yep. And that's an expensive process to go through. So I'll pause there. I know I shared a lot, but that's, I think from an infrastructure perspective, we need something like that is very cloudy. Right? Yeah. Cloud meaning scale and down and have the right security controls.
Well, it's interesting the comparison to Netflix, because for Netflix, it's more about bandwidth and scalable bandwidth and some processing power. But I think your vision, I love it that you blew it up like that. It requires all of that too, processing power and bandwidth and all the connectivity, but it also requires all the data to inform the decision making. I'm actually working on an article now that talks about augmented clinical voice recognition and an ambient clinical voice to replace the documentation for the provider. And then as I thought about it more, that technology, which originally, right now is focused on how do I make the doctor more efficient, is going to do what you described, Atif, which is it's going to understand what the patient needs and maybe can even take care of the patient in a virtual visit if it has the right data. I mean, so they're working on that technology, which, you know, so it's a big vision for sure, but it's definitely closer than I think we realize. Marlon, what do you think? I mean, let's talk about Atif's kind of perspective there. What's needed to make that happen?
Yeah, so I think what's interesting is how you define the experience of telehealth, right? And so today we sort of come to establish the benchmark as being a video experience. But when video fails, what happens? You default to audio. You ask any provider today in terms of what are your counts, what are your metrics, and they will give you audio metrics. They will give you telephony metrics. They will say we've had to scale our contact center by, you know, 5-fold, 10-fold, right? Not everyone is doing video, right? But what's inherent in the pathway of communication is the notion of data is being exchanged. Data is being shared. What Atif alluded to was the notion of how do you leverage that data richly through AI and ML tool sets to inform the practitioner, to inform the collaboration in a manner that the experience of telehealth is beyond personal care and brings a research entity in terms of the use of that data through the AI ML logic as part of an engagement, right? Infrastructure-wise, plain old telephony service that we thought would have been eradicated by technologies like voice over IP is not going away.
Right.
So service providers still have a play. Healthcare providers, you know, they still have a play. They need those plain old telephony services, regardless of boundaries in terms of regulatory domains, regardless of state lines, right? Because an 800 number could be advertised across the state, across, you know, North America, if you wanted, in terms of the expansibility of practicing telehealth services. So fundamentally, I think there needs to be a recognition that access in terms of communication, audio is a constant. Video, great to have. The internet has become the new network for most organizations, right? And that poses a number of security and privacy challenges in terms of behavior. But that too is another pathway that needs to be part of the infrastructure dynamic or decision for organizations looking to actually provide telehealth services. The richness of those two pathways will allow for capabilities, is what Atif was alluding to actually be leveraged in terms of AI and ML. And additionally, the richness of those particular infrastructure pathways from a patient perspective with technologies like 5G on their endpoints now will allow them to actually, you know, consume telehealth across the nation, not just within a particular state. So I think infrastructure has a lot of dynamics, a lot of nuances to it. Policy, regulatory domain guidance influences that, but availability of access in terms of infrastructure, it's not 100% in the US, nor in many nations, but I think it's there fundamentally as far as audio to still enable telehealth services to be created and offered by actual healthcare providers to their patients.
Yeah. And unfortunately, it feels like it's going to create a bit of a have and haves not, you know, both on the provider side and the patient side. On the provider side, who can afford to invest in the AI and the machine learning to be able to augment these things, and who can't? And then even on the patient side, who has access to 5G and who doesn't, or, you know, or whatever technology. And then I think there's also just some, you know, I think that it'll be interesting to see how it evolves for a patient, because for me as a tech guy, I mean, literally tech guy on Twitter, like I think I will soon reach the point where if a doctor's not using AI to augment what they're doing, I probably don't want to go to that doctor. I won't trust that doctor. But I think other people may say, oh, if they're using it, I don't trust you. So I think there's some interesting trust challenges in this as well. Stacy, are you ready to see an AI doctor, or AI powered doctor?
Yes, in a word, yes. So much to unpack there. And Atif, I love your vision of sort of flipping the script of saying, you know, a virtual health or a telehealth visit is what comes first. You know, what can we do via that. And then if we can't handle it virtually, what can we do, in person? And in my lifetime, and I plan to be here a lot longer. I just hit 6-year survival, beating the odds. But thank you. I plan to be here a lot longer, and I hope in my lifetime I see it work out that way. So in the patient community, we have sort of an adage when we develop our messaging for advocacy and awareness, and that is meet patients where they are. Go to where the patient is. Okay, and so what do we see now with all the Gen Z patients and everything? Where are they? They're on their phones, right? Everybody has a smartphone. They're all talking to each other via social media, on their smartphones. That's where the patient is. I don't know what number we're down to now on percentage of Gen Zers that have a PCP, but I'm believing it's in the teens. So that generation of patients is not establishing a relationship with a physician, doesn't even, again, in my lifetime, won't even know what a PCP is. And it's going to be a very episodic type of care that they want to get on their cell phone, similar to the Netflix experience, an on-demand healthcare experience. So again, everything we're talking about, how do we make that happen for patients? What is the infrastructure? What is the legislation that can travel across state lines and move with the patient? Because certainly that's what they're doing. I was trying to think, there's so many things I wanted to say, but I am ready for that type of experience. Oh, the other thing I wanted to say was the amount of education and health literacy that goes into this. We are sitting here as sort of tech-savvy, tech executives talking about all these things, but your average patient is, again, as we said, fearful of technology, skeptical of technology, doesn't know how to use it or maximize it. So as we are developing these, AI and ML type of modalities, we have to absolutely commit to health literacy and educating our patients how to use them. In particular, those with impairments, a telehealth experience, what does that look like for somebody that's visually impaired or hearing impaired? Or how does that look for our senior citizens or somebody, with a learning disability? Again, I just want all of us to commit to, as we're developing the technology, to develop the education to support the patients in using it. And then the last point I want to touch on, John, and you had said this as well, is access. It personally bugs me that health systems assume that patients have connectivity to be on a patient portal. It's like, oh, this is all going to be available on your patient portal. Well, what if you don't own a computer? What if you can't afford broadband access? What if you're, especially in the pandemic, you're just trying to pay your bills and keep your lights on, but yet you have to go to a patient portal? Again, how are we working together to ensure that type of access and close those inequities in our communities to have access to those, basic patient portals? And here we are talking 10 steps beyond that. So let's keep our eye on the basics of ensuring patient access as well. So
let's dive into that. Sorry, were you going to say something, Dr. Mathew, or was that Marlon?
It's Marlon.
Okay, go ahead.
That's why I took the time. What Stacy said is exactly the challenge, right? We're in this transformation of leveraging digital capabilities, yet we need to actually identify how are these capabilities going to be utilized and consumed. And yes, the Gen Zs and the next generation are going to come forth, and they're going to be very much different than how, the bulk of us older folks have been using communication capabilities. There will be a transition in terms of maybe to that phase and stage where Atif mentioned, ideally, we'll have assistance in terms of AI and ML. That's the system capability. But the access in terms of connectivity and the modality of communication, audio has to be fundamental. You cannot assume telehealth is all about video. Video, yes, will become commoditized, But the basic tenets of telecommunications is A, you and I have to agree on the means of communication, number one. Number two, we have to agree on the language of communication, right? So yes, I can actually connect with Stacy, but Stacy speaks, another language. I need to now factor in as part of my engagement capabilities with Stacy that I may need interpretation services. And that's a big factor in telehealth services that we've seen through this time, that organizations are now having to redouble and figure out 40% of my communication is with the Spanish-speaking population for one provider in Texas. How do you actually create a virtual care interaction that starts maybe with video, but then you need to go back to an audio modality to engage in a language interpretation service, provider? So again, audio, let's not get away from the fact that basic telephony, whether it's over VoIP or it's actually through plain old telephony services, we can't get away from that. I think we need to recognize that as we look to the future with these new technology capabilities.
John, if I may, I want to follow up with what Marlon's saying, because I think he's pointing out a really important point, which is let's not overthink it. Sometimes if it ain't broke, you don't need to fix it. But to take it either step back, and I know we don't have a lot of time, this moment where we have all these digital technologies and all these other historical technologies that worked well together allows us to look at how we design our healthcare systems. If you look at the last 20 to 30 years, all we've really done is make existing processes efficient, which is some type of caregiver delivering care to someone or doing something to someone. I think Atif, you mentioned the word collaboration a lot, and I think that's actually a key word when we start thinking about the patient. We need to stop looking at it as we're doing something to someone and being a separate, siloed incumbent, whether I'm a hospital or a pharmaceutical company or any type of other system, and really look at it as if I was designing this with the patient as my collaborator, how do I inform my partner or collaborator with the right information that they can make the right decisions? Or I think, as you had mentioned, create an AI aid that would allow them to have some type of decision support to work with me to get them the best health. Again, I know we don't have a lot of time, but to go through that type of redesign or rethink would change a lot of what we're dealing with now, because it's still, well, how do we get the doctors to see more patients? How do we get more of this, more of that? It should be,
have to change the metrics.
Got to change the system to how do me and Stacy work together to make sure she gets the best health and that the full outcome hits the right goal and she gets information the way she needs it to make the right decisions for her.
Yeah, Atif, you want to chime in there? It sounds like that was somewhat of your vision of where we're headed. Is that right? Did we lose him?
He's there. Atif, can you hear us?
Yeah, sorry, I couldn't find the mute button in time.
No worries, happens.
Yeah, I think everything that was just shared is spot on, right? And we need to put the patient in first and build the capability around them. Like typically, what we have done in the past is build the capability around a physician or even the healthcare insurance company, what they need or what the physician needs. But in this case, the patient, which is the customer, we should build the capability around them and meet them where they are, as Stacy said. And the point about 5G and what Dr. Mathew just said, also, it is going to, I think, totally change the dynamic of how this whole thing would look like in the future. 5G, from what I've read, is better than your laptop connection hardwired in. And if that is the case, imagine using high def camera on your cell phone that is able to scan your area that you want to talk about with the physician. It just totally changes. And then think about the time saving, the productivity, instead of driving to an office, sitting there, and then maybe you have kids, and how do you take care of the kids while you're gone, and blah blah. So all those complications kind of get simplified. So what it should do technically, drive the cost of healthcare down, because members are more engaged, patients are taking control of their life a little bit more, or their care pathway a little bit more, and essentially it should, data suggests, keep them healthier, and hence reduce the cost of healthcare, which is very, very high for the U.S. compared to other first world countries. They're number one from a GDP perspective. 7.3% or 14%, I forget the exact statistic, but it's highest of all.
Yeah, well, and the reality we're facing is that we need this. We need this change. It's unfortunate that COVID had to inspire the change, but it's here. Dr. Mathew, unfortunately, we're out of time. Do you want to give us some final thoughts? Give us some final things to take away as we wrap this up.
I think a lot of. I mean, I wanted to say thank you to Stacy, Atif, Marlon, and you, John. If anything, this should give people hope that we're all trying to figure out how to make this work and actually make it work better than it has. Obviously, the pandemic's been horrible, but if there's any silver line that's come out of it, it's the fact that we realize that we can't do this alone and can't do it in a silo. We have to figure it out together. But by together, Atif, you mentioned something I thought was kind of an interesting point, about the whole, the patient as a consumer and whatnot. And I know it's been thrown around a lot, but I want to throw it out there is we have to look at them as a partner and a collaborator. When that happens and we look at how we design it, whether it comes to regulations or data privacy or siloing, everything gets designed around that because the use case is defined properly. And I think, like I said, with the folks like on the phone now, the way that they're thinking, it seems that we're all aligned going towards the same North Star on this, John. So yep. I have hope. Which is good.
No, that's great. I love the comment about collaboration. I mean, the fact that we have DXC, Cisco, Red Hat, and a patient all discussing this. I mean, it's a small start, but at least that you guys are working together. We're listening to patients in a way that I think wasn't done previously, and I think those are all good signs. And thanks everyone for watching live. There are a few questions. One of them, I think we may have to throw to Twitter. We'll have to answer on Twitter after the event. But they said, how does open source technology support virtual care? I think the few people on this call have answers there, so we could hop on Twitter and share with you with the HITSM hashtag, a response to that, Sean. And Vince made a great point as well that I think is a great way to wrap this up. He said the issue of whether telehealth is a substitute or additive to utilization and cost is really critical. And I think that's kind of what we're talking about here is how do we pay for this and how do we make it additive and how do we make it more effective for the organization but still pay our provider and clinicians what they need. So I think this is a conversation we're going to be having for the next couple of years, but thanks for adding some great insights, and thanks everyone for watching live. If you want to check out the recording, we'll be sure to post it at healthcareittoday.com. Thanks everyone for participating.
Thank you, everyone.
Have a great day.
Thank you for having me. I appreciate it.
Yeah.